Hello and welcome everyone. I'm going to do this presentation a little bit differently. You can't see me on the screen because I'm recording on my iPad. The goal here is that I can draw on my screen with a little more finesse than what we've seen in the past when I've tried to do lectures with you guys and trying to draw. Sometimes it's not always so nice and clean. So this should make life a little bit easier. Just going into the conduction system of the heart today and get you guys comfortable, kind of a refresher on a lot of points. And it wants to draw on things. Okay. And it doesn't want to advance. What the crap. There we go. Okay. Now, we're going to cover a lot of different systems or pieces or specialized structures today, all the way from the SA node to the Purkinje fibers. So we'll go ahead and we'll pass forward with that. Do want to take a few minutes and look at this picture, typical generic picture of the heart. But at the top of the right atria, we are specifically identifying the primary pacemaker site. And that primary pacemaker site is the SA node. And then from the SA node, you have these little pathways. You can kind of see them here. They kind of show arrows. Those pathways are considered those internodal pathways, and they are transmitting electricity down here to our next spot, which is the AV node. So I do want to point out that the heart has some features available to it. It knows that it has to have a backup system in the event of an emergency. So if the SA node should fail, then you have to have a backup generator. The AV node is the first in a line of 3 points that will help as a backup generator. So the AV node is the first one. It will fire at a rate of 40 to 60 beats per minute. It really tries to give that SA node time to try to fire before it will take over. And then right next to that AV node, you come through some tissue and you end up at the next structure, which is called the the bundle of His. So sometimes that's referred to as the bundle of His. It's the most common way it is referred. And we have the same intrinsic rate here. It's 40 to 60 beats per minute. Now, once you leave this, it's going to travel down the bundle branches, and it will wrap around the bottom side of the heart to feed that outer layer, and that's known as the Purkinje fibers. Those Purkinje fibers are your last stop in the how do I keep from dying mode, and they fire at a rate of 20 to 40 beats per minute. So just kind of review so that you guys can remember how that works. And when we talk about the SA node, we did say it meets up here at the top of the right atria. It's close to the superior vena cava, and it is considered the primary pacemaker site. So it will control the heart rate. It should be 60 to 100 beats per minute. That's what's normal for it. But we can manipulate this number, and that's what we're going to look at next. So because this system is innervated by both the sympathetic and the parasympathetic nervous system, that is how we can adjust or tweak that 60 to 100 beats per minute. So the sympathetic nervous system should do what to the heart rate? Sympathetic nervous system will increase the heart rate. On the flip side, the parasympathetic nervous system, that's our feeder breed, it is known to slow the heart rate down. So we can adjust and manipulate as needed with that. Now, another point of reference on here is where we get the blood supply to that SA node so that it can properly function. And it comes from the right coronary artery. So if you remember, you have that aortic arch, which I know it's up here in the picture, but at the base of that aortic arch, which you can't see here because it's covered up, but you have a right and a left coronary artery, and that right coronary artery comes off, and that is where the SA node receives its blood supply. So you can imagine if you were to have a blood clot, a big myocardial infarction that impacted that right coronary artery, it could have very big detrimental effects on your heart's ability to function. Now the next node, that electricity will travel down those internodal pathways. They're going to meet up here at the AV. That AV is meant, it's known as the junction. So we talk about the junction as it relates to the atria and the ventricles. So if you can imagine the atria and the ventricles, we're talking about this little bit of meat here that's in between the two. So we're looking at this stuff right here. So that AV node is meant to slow down the electrical conduction. It does that because you had blood that was here in the atrias. That SA node fires, sends the electricity down the line, causes that muscle to contract, and it will shoot down and it starts filling up the ventricles. Well, by slowing this conduction down, we're allowing time to get this blood in here fully. So we want to fill up these ventricles as much as we can. So slowing down that conduction for the atrial kick gives us the ability to contract and push that blood down and give it time to fully fill up. Now, we did say that, you've got a backup mechanism. This AV node will act as a secondary pacemaker in the event that the SA node fails. And because it is a backup generator, it's 40 to 60 beats per minute. Excuse me. The AV node communicates with the bundle of His. Remember, it's over here. There's our bundle of His. And those two are very close together. And that will allow that electrical impulse to travel down the bundle branches and into the ventricles. So that bundle of His is another area we have, also sits at a intrinsic rate of 40 to 60 beats per minute. There it is. Now those bundle branches, they will pass down. So if we were to draw, that was rude. So if we were to draw that, let's see, where are we at here? If we were to draw that picture over here, so you have your atria up here, you have your ventricles, and you have AV node, bundle of His, electrical impulse travels down those bundle branches, swings around here into the Purkinje fibers. Those Purkinje fibers are your final destination. They are the last chance your body has to save itself. They beat at 20 to 40 beats per minute. Third and final primary pacemaker site. Okay. So just another picture to show you how that electricity travels. Now, when it comes to the EKG, you need to remember that the EKG reflects electrical activity, not mechanical. If you want to assess mechanical, you need to be checking a pulse. You need to look at the blood pressure. So EKGs are about electricity. Mechanical is about your pulse. Okay, are you producing a contraction? So you can have someone who has electricity traveling through, but it may not create a pulse. And that's where we talk about pulseless electrical activity, PEA, and we start talking about those different things. Now, an EKG can tell you about rhythm disturbances, and it can also tell you about conduction disturbances, but it cannot tell you about any structural disorder or perfusion disorders. So don't look at it to tell you that. Now, we did mention that you have, again, just another picture of the heart here with your electrical conduction through the heart system. And I'm gonna scroll this picture up here because I want to take a look at it real quick. Remember, we talked about the sympathetic nervous system and we talked about the parasympathetic nervous system. We know that the sympathetic is meant to increase heart rate, parasympathetic is to decrease it, right? So I just want to kind of point out something here. The sympathetic nervous system will innervate the whole heart. We can increase the heart rate here in the Purkinje fibers with no problem because the sympathetic nervous system innervates the whole heart. But let me ask you a question. Do you really want the parasympathetic nervous system that can slow down a heart rate? Do we really want it to influence the Purkinje fibers? The Purkinje fibers beat at a rate of 20 to 40 beats per minute. Do we really want the parasympathetic nervous system to slow that down? No, you do not. So the parasympathetic nervous system innervates the top half of the heart, not the bottom. We do not want to slow down any more than we have to. So zip that back out. So again, your AV junction, meaning the bundle of His in the AV, 40 to 60 beats per minute. These are your inherent. The other term they use a lot is intrinsic. And the ventricles there at the Purkinje fibers beat at 20 to 40. So the general rule is that whoever has the fastest rate is going to be the one that's in charge. So we know that the SA node at a rate of 60 to 100 should be the one that is in charge. But you can have places that get irritable, and that can cause an overriding of a higher pacemaker site for control of the heart. And we're going to look at what that looks like later on. We're not going to get into it right now. But you can have places that get irritated. They get really cranky, and we'll talk about that each week. And you can have an escape mechanism, and that escape mechanism is where you have a normal pacemaker, but it slows down or it fails, and so that whoever is below it is going to have to take over. So you may have an instance where the SA node is firing just fine, and then it decides to go on vacation. And when it does, the AV node is going to sit here and go like, what is going on? And then all of a sudden it's going to go ahead and it's going to conduct its electrical impulse because it has to. Okay? Oh, and here's the picture I was referencing. So that sympathetic nervous system can innervate the atria and the ventricles. It's going to increase our heart rate, the conduction, and it can also cause some irritability. But the parasympathetic nervous system is only going to innervate the top part of the heart. It is not going to do anything down here in the ventricles. We do not want to slow those Purkinje fibers down. Now with your lead placement, when we're always looking at lead 2, I want you to think about it in terms of a camera. So if you can remember the old style cameras, you have this nice little camera sitting down here, and it's in this section because it has the clearest view of the entire heart. So it can see all the electricity as it's traveling toward the camera and anything that's traveling away. So that's why we like it so much. Let me erase this out just so we can clear that. Oops, maybe I won't clear that. There we go. And with that, when you have this camera here, and I'm going to go ahead and I'm probably going to have to go ahead and move forward so that you can see this. But this camera is catching the electricity. As that electricity is traveling down the line, remember you got It's coming down here from the SA. It's going to meet up at the AV. These guys are going to come down and meet up at the AV. It's all that electricity is traveling toward the camera. And this is probably the hardest concept that students struggle with when they're first starting out with EKGs. Anytime you have some sort of impulse that's traveling toward the camera, it's going to create a positive inflection. But where we struggle is because it looks weird because it's traveling down toward the camera this way, so you think, well, that should be negative. But it's not. It's actually anything that's traveling toward that camera is going to create a positive inflection. And then if it moves away from the camera, for example, when those internodal pathways have to turn and come up this way, it's moving away from the camera at this point, and that's going to create a negative deflection. So electricity traveling toward the camera creates an upward inflection. Going away from the camera causes a downward deflection. And that's really what we're seeing here. Okay? So if it's traveling toward the camera, it's going to create a positive upright swing. Okay? If it's flowing down, it's going to go negative. Now I know this gets a little complicated here. We've got extra stuff it's talking about. If you stick with me and follow the Keep It Simple Stupid, we're going to get you through it, okay? Now with your graph paper, you have the ability to measure in voltage. So it's comparing the height of the spike on the paper. So it's looking at how high it goes. That's your voltage. And you can also measure in time. So this is important. When you're looking at the graph paper, excuse me, let me back up here. You will see that you've got these really dark shaded points, and then you have the little light ones here in between. So each little block is 0.04 seconds. But if you measure this whole block, this is 0.2. So if you took 0.04 and you multiplied it by 1, 2, 3, 4, and 5, you have 5 blocks there. So if you multiplied that by 5, that gets you 0.20 seconds. Okay? So we can measure voltage and we can measure time. And each time you have a cardiac cycle, it's going to create a pulse. Okay? And a cardiac cycle is when the P wave all the way to the T. So you're looking from here to here. You're going to have a pulse. So each time you have a cardiac cycle, it should produce a pulse. Now there's some points of reference on here that we want to talk about. And I think, let me spoop forward here for just a second. Yeah, definitely want to do this here. Okay. So I'm going to take a little time. We're going to do some drawing and we're going to kind of look at this together as a class. And I'm going to go ahead, I'm going to use the orange. And I'm going to use the orange to represent the atrias. Okay? And then I'm going to use the green to represent the ventricle. And we're going to go back here and we're going to talk about using, we've got the camera and it's all about that positive inflection to be able to identify what we're seeing, okay? So with the camera being down here, it's looking at the electricity as it's traveling through the heart. We know that anything that comes toward the camera is going to create a positive inflection. If it moves away from the camera, it's going to create a negative deflection. So, when that SA node, which is up here, fires, and it shoots electricity down to the AV node, it's traveling toward the camera. So what you need to do is you need to look at this point here. This is referred to as the isoelectric line. Okay, so this is the isoelectric line. It is our starting point. Okay? When that electricity leaves the isoelectric line and starts going up, it's traveling toward the camera. Okay? So we'll just say, see here how it's traveling toward that AV node. You got those little intrinsic pathways traveling to the AV node. Okay? And then that is an upward deflection. And then you also have it has to come over here and hook in here. And I want you to think about it. When it has to return and make its turn to come back up here, that means it's moving away from the camera. So we're going to have a negative deflection. Okay? When you see the P wave, that P wave means that the atria have fired. So you have atrial contraction. I'm going to use CTX for contraction. So P waves mean that the atria has contracted. Now, if you remember, we said there was always going to be a slight pause. Let me use a different color. Oops. There's going to be a little bit of a pause because what happens, we got to have that atrial kick. We want to give it time to fill, the ventricles to fill, before we allow the ventricles to contract. So you have this little bit of a pause here, and that is normal. When they measure intervals, because the intervals are another thing that we can talk about, intervals are measured from the beginning of that P wave when it comes off the isoelectric line, like we talked about, to the point where it leaves or comes off that isoelectric line. So this can look a couple of different ways. Let me come over here and change colors again. So it could be that you have, I'm going to come up here, you may have a P wave, all right, and then it may just come here, and instead of dipping down like you see in the drawing that the book provides, it may automatically leave and go into this upstroke, and that's okay. There's nothing wrong with that. But what you're measuring, that PR interval, is measured from the point it leaves the isoelectric line. So whether it's here or whether it's here where it's coming down into a downward stroke, doesn't matter. So your PR interval. The PR interval, or PRI for short, should be no greater than 0.20. So the PR interval should be no greater than 0.20 seconds. So it should be no greater than one big block. Okay, remember, you take 4 of the 1, 2, 3, 4, and 5. You take 5 of those at 0.04 apiece. It comes up to 0.2. They should be no bigger than 0.20. Okay. Now, the next thing that happens, because we're still up here, so going back to our heart here, we've got the electricity, we traveled here, now we've come through, and it's really close together, so you don't really see a whole lot of electrical movement here. But all of a sudden that electricity has to travel down those bundle branches, and is the electricity coming toward the camera? When it travels down those bundle branches, it is traveling toward the camera. And because it does that, you're going to have a positive inflection. So here comes that electrical impulse. Right there it is. So that's a nice positive inflection. That tells you that the electricity, and I'm going to come back over here to our picture, that electricity is traveling down toward the camera. So that's a positive inflection. That's part and parcel to it. Now, the electricity then, let me come over here and change colors. Oh, I'm so limited on colors. This is so sad. Okay, here we go. The electricity is going to swing around and it's going to travel up those Purkinjes. But when it does, it's moving away from the camera. So guess what happens on your EKG? You have an EKG where it stops working. Okay, here we go. You have an EKG where suddenly you have this downward deflection because it's moving away from the camera, and that means that it has traveled to the end of your Purkinje's. So that is known as the QRS complex. That QRS complex tells you that the ventricles have contracted. So a QRS means that you have ventricle contraction. Now when our heart decides to repolarize, it's gonna, when it resets itself, it goes in reverse order. So that electrical impulse, just like a swing, if you swing, that swing is going to go all the way as far as it can go, and then it's going to have to come back the direction of travel. So guess what? It's traveling toward the camera again. So now you have this upward inflection on the T wave. And then what's it going to do? It's going to make the turn, and it's going to go away from the camera. So guess what it does? If it goes away from the camera, you're going to have a negative deflection. That, when you look at that T wave, this T wave is telling you that the ventricles have repolarized. So it's resetting. Now there's an important note here. If you can get to the apex of the T before your next electrical impulse comes through, you're good to go. I know we'll get into that here in a slide or two, so I'm going to let that probably ride for a second. Make another point of reference. Your QRS complex should be no greater than 0.12. Now these are important numbers you must memorize because it's going to help you when you're trying to identify EKG strips. So again, the PR interval should be no greater than 0.20, and your QRS complex should be no greater than 0.12. Now there is another interval we talk about. It's called the QT interval, but we will get to that QT interval later. The QT interval is measured from the beginning or the upstroke on the Q, so it's looking here, and it goes to the end of the T. But we're going to get into that later on. So let me see if there's anything else I need to add here. No, I think we're good. I'm going to come back. We're gonna hit on this whole concept here about the T wave in a minute. Now your QRS complex can come in a variety of configurations. So really you need to, and when we talk about this when we meet up in class, I'll explain it a little bit more in depth, but you want to find what you recognize and start from there. And I'll explain this later, but you can see how it appears in different ways. You can have the Q down here. The Q could come straight off the isoelectric line. That gives you the QRS. There's a Q, the R, and the S. There's a lot of ways where this can present. Don't let this get you hung up. It will become second nature. Now, some other little things of reference that we want to point out. Your muscle tremors will have this weird impact here in this area. A lot of times if you have someone who has a respiratory complaint, if they're really short of breath for whatever reason and they're struggling to breathe, the muscle contractions that it takes for them to breathe because they're struggling will create these muscle tremors that will appear on the EKG, and you'll be able to see it. They're very erratic. If your patient is on the cot, you know, we have that patient that suddenly they decide to shift and they do a big move and they shift on the cot, it will create this big crazy electrical reaction. It's just where they're moving their body around to resituate and sit on that cot. If you see something that looks like this, it's an indicator of an loose electrode. And there's a thing called 60 cycle interference, and it's kind of hard to see, but it's almost like you've got this little teeny tiny thing. Usually when this happens, it's the result of the EKG being plugged into the truck. Usually if you unplug it, you can get it to stop. But it's called 60 cycle interference. This is what I knew we were going to talk about. So there is a point in time, remember this is your P wave. Here's your QRS complex, okay? And then we have the T wave, and the T wave indicates that the ventricles are resetting. So we are repolarizing, okay? Ventricles are repolarizing. It's going back to zero, so we're resetting itself. There is a thing called the absolute refractory period. It occurs from this point here, where the QRS starts to fire, and it comes to the apex of the T. That's when the heart cannot tolerate another electrical impulse. If the heart should get another electrical impulse during this very delicate time period here, it will send that person into cardiac arrest. It will send them into VFib. Okay? That's why they don't want football players to spar each other in the chest with the helmets, because of the fear that it will hit during this absolute refractory period and send that person into cardiac arrest. So that is called the absolute refractory period. That's the time where we do not want another electrical impulse to travel because the heart has not had time to fully reset. Now there is another period from the point of the T wave at the top of the apex there to the end of it. This is referred to as the relative refractory period. And this is when enough of that ventricle has reset itself that it can take another electrical impulse. So it is possible to have another QRS complex come in and hit here, and the heart can tolerate it. It's considered the relative refractory period. It really doesn't like it. It's not happy about it, but it can function. And I think this is going to give us everything we need. Oh, no, I apologize. There are a couple more slides left. We do want to talk about how you calculate the heart rate. When you're talking about National Registry may not give you, because God love them, National Registry may not give you a full 6-second strip. You may only get a 3-second strip or some weird random version of a strip. So if you don't get a full 6 seconds, you won't be able to count the number of QRS complexes in that rhythm to come up with an answer. So you have to use one of two methods. You can either count between the two R waves. So remember, if you've got a QRS complex, so there's your P, there's your QRS, and then there's your T. There's your P, there's your QRS, and there's your T. So you can count the number of large squares between these two R's and divide into 300, or you can count those little itty bitty itty titty tiny squares between the two R waves and divide it by 1500. So it really depends on how you want to do it. This is not as difficult as it used to be because they now allow you to use the calculator when you test. So you do have that ability. Just remember that you can either get a really solid, accurate number by counting the number of small blocks between those two R's and dividing it by the 1500, or you can get a roundabout average amount by counting the big blocks at 300. You can also use a heart rate meter where you place the R wave. Let me see. There we go. You place the first R wave on top of that line, and then you look to see where the next R wave hits, and that tells you the heart rate. There's this quick check sheet that tells you, the number of large squares and what the rate is. But what you're going to use in class is a 6-second strip. So you count the number of R waves that appear in that 6-second strip, and then you're going to multiply that by 10 because there's 60 seconds in a minute. So that is the way, for class purposes, you will do things. So if we were to look at this EKG strip really quickly, you will see that this is a 6-second strip. This is 3 seconds. That makes it 6. So you have a total of 6-second strip here. And we're going to count the number of QRS complexes. 1, 2, 3, 4, 5, 6, 7, 8. This gives us a heart rate of 80 beats per minute. Okay? And we know this is a good solid 80 beats per minute and not something weird, because we do have the P wave shown at the front and we have a T wave shown at the back. So that's a solid 80 beats per minute. I hope this has kind of helped get you through and show you those key concepts. Please come back and review this slideshow when necessary, because it's going to help guide you for the rest of your presentations. And if you have any questions, please feel free to give me